Hello, everyone. My name is Shadi Reyes. I'm from the Medical Center. Welcome to the DMC Medical Group webinar series. We come to you every month. This is the first time we come to you at 7 p.m. We change the time based on the multiple requests. And today we're going to have our guest speaker is Dr. Zahir Hakim. He is one of our interventional cardiologists and has a special interest in PFO closure. His topic for today is cryptogenic stroke and PFO closure. My co-host is Dr. Kenton Zer. He is the director of the marketplace of cardiovascular at Dayton Medical Center, and he is our cardiothoracic surgeon. Please use the platform, the Q&A or the chat box for any questions to the speaker. We'll try to trickle these questions throughout the talk, as well as we'll save some 10 minutes at the end also to entertain questions. For some other housekeeping items as well, we're going to be recording this session. So if you missed it or you're going to use it as a reference in the future, it's going to be hosted on our YouTube channel as well. Again, with no further ado, I would like to hand it over to Dr. Kenton Zer for introduction, and then from there, Dr. Hakim. Thank you so much.
Thank you, Chadi. And this is an interesting subject for me because this subject is where it used to be in our wheelhouse. I mean, this is something that, we used to close them all surgically, and it was pretty obvious that this was one of the first structural defects to be able to be routinely closed in a non-surgical way with very, very good success. And it's so much better than getting your chest open to get a small closure device. And so I applaud the efforts of the cardiologists to get this, to kind of take this under their wing and be very effective with this. And Zahir's one of our busier interventionalists at the DMC, very good with his hands and wire work and such. And we look forward to hearing what he has to say.
Thank you, Shadi and Dr. Zer, for the introduction. So today we're going to talk about an interesting topic and that has been evolving for the last few years. And new treatment get approved just recently. I mean, a couple of 4 years ago, it was FDA approved to close the PFO by closure device. So the two main closure device were recently approved. So we're going to move forward with our topic today about cryptogenic stroke and PFO closure. Stroke is very common and it's the fifth leading cause of death in the United States. And also it's the leading cause of preventable adult disability. In 2013, some stats that there were around 6.5 million stroke-related deaths worldwide, accounting for 11.8% of total death. That's a huge number. Strokes also cost a lot economically, around $34 to $36 billion each year. Also, this estimate and this cost comes from healthcare, medication, missed work days, and everything related to it. We have mainly the strokes are divided into two main types. I mean, either hemorrhagic stroke or ischemic stroke. Usually the hemorrhagic comes from a vessel ruptured. Ischemic stroke comes from multiple sources, either an artery occlusion, atherothrombotic, or 15 to 20% come from a stenotic artery feeding the area. 25 to 30% is cardioembolic source, like a thrombus that's coming from the heart. And we have 15 to 20% like lacunar or small vessel stroke. And we have 25 to 30% cryptogenic stroke, like from unknown cause. And we're going to focus on the cryptogenic stroke because this is a percentage that will benefit from the closure. And we have 5 to 10% other reasons and cause. So the septal abnormality of the heart, the interatrial septum, was described initially by Leonardo da Vinci in 1513. And he described it he said, I have found from a left auricle to be the right auricle, the perforating channel from A to B. So he described it when he dissected the heart, that there is a connection between the left auricle and the right auricle. And then in 1877, there was a German pathologist who discovered a relationship between the stroke and the PFO when he performed a necropsy on a 35-year-old female who had a fatal stroke in her frontal lobe, and he found a long thrombus in her lower extremity and also a very large foramen ovale through which he could pass 3 fingers. So at that time they connected both together, a stroke with a thrombus and the connection between the right and left atrium. So what is PFO? I mean, we should go back to the anatomy where the foramen ovale is, we go back to the embryo, is an obligatory channel during fetal life, and it's very necessary to provide the oxygenated blood to the fetus or the baby, to the circulation of the fetus. And then an incomplete postnatal fusion of the septum primum and secundum will result in a patent foramen ovale. When the patent foramen ovale is present, there will be sometimes transient or continuous right to left shunt that can lead to paradoxical embolism. So either there's always be a connection and the blood will move from the right to the left side of the heart, or it will be transient, like from time to time, when the pressure in the right side of the heart will increase, and then will push some elements to, or blood, will push the blood from the right atrium to the left atrium. Like when we cough, when we sneeze, it can increase the pressure in the right atrium and can allow the blood to pass through the connection to the left atrium. And also sometimes the presence of some septal aneurysm can also be associated with, can increase the association with cryptogenic stroke. So here's some stats about how many strokes, I mean, and how much it costs to the healthcare system and to the economy. But also we're going to focus, again, it's the same stats, but it's divided to see which category of patients we're going to focus on. So from the ischemic, like that represent most of the strokes, 25% of them, they have cryptogenic stroke. From the 25% cryptogenic strokes patients, like 40% of them, they have PFO, 40% of them. And we're gonna divide them to like below 60 years old and above 60 years old. The reason, because the younger age, because it's most likely below 60 years old to be related to the PFO, the stroke to be related to the PFO. Above 60 years old, despite having PFO, despite the presence of PFO, there could be other reasons behind the strokes, like arrhythmia, the increased risk of arrhythmia, like atrial fibrillation, or atherosclerotic, or stenotic disease, or other causes that can cause the stroke. So we'll focus on this group of patients that are less than 60 years old, they have PFO, and they are labeled as cryptogenic stroke. So for the PFO, we start how we evaluate patient after when they get stroke. So we start usually with surface echo, or we call it transthoracic echocardiogram, with agitated saline bubbles. The purpose of giving agitated saline is to see if there is a connection, or if there is any PFO in the heart, or any connection between the left atrium and the right atrium. And the best view is standard apical 4-chamber view to see when the bubbles pass through this channel or through the patent foramen ovale or PFO. And the timing of the bubble appearance in the left side of the heart is very important. So if the bubbles appear quickly, or pass quickly or appears quickly in the left atrium, that support the diagnosis of PFO. But if they become late, like after 5 to 8 cycles, that may indicate that it's could be related to atrial venous malformation in the lungs more than PFO. So also after the 2D echocardiogram, we have also another test like the transesophageal echocardiogram, which is the gold standard test for PFO because it can clearly identify the anatomy and the detail of the patent foramen ovale or the PFO, and it can give us some details like the tunnel lengths, the margins or rims, and surrounding structure like the aorta, the superior and inferior vena cava, and also the pulmonary veins and the coronary sinus. There's also another very high sensitive test. It's called transcranial Doppler, which also rely on the injection of agitated saline. And then we check in the Doppler signal in the middle cerebral artery. We check if there is any signal of the bubbles passing, and it will determine the grade of the PFO, if it's high grade, low grade, or medium. It depends on how many bubbles and the signal strength. Here is some view, like you can see also an intracardiac echocardiogram. It can also give us details about the PFO, and usually we use it like intraoperatively more than for diagnosis. We use it to guide us during the closure, and also some fluoroscopic views. And here in the middle, you can see the relationship of the foramen ovale with the surrounding structures, like with the tricuspid valve, the inferior vena cava. So, and you see all the rims around the foramen ovale, like the superior rim above and the aortic rim, and also down you can see the IVC rim and the posterior rim. Here there's a comparison between the 2D echocardiogram and the TEE. Like both of them are indicated and useful to diagnose the PFO, but we start usually, like I said, with the 2D echocardiogram. And actually the surface echo, it's easier for the patient to perform Valsalva maneuver during saline injection. It's very important to perform Valsalva maneuver during bubble study because we need to increase the pressure in the right atrium, because for the bubble to go from the right side of the heart to the left side of the heart, there should be a transient increase in the pressure of the heart, and there should be a shunt. Sometimes it can pass without the Valsalva maneuver, but most of the time, to get good results, we need a good Valsalva maneuver, and we need to increase the pressure in the right side of the heart. Also, we need adequate amount of the bubbles across the septum. So the technique of the study is very important to have good results. So 2D echo is very good to start with, and also allows for a better Valsalva maneuver with during surface echo. The patient will be awake and can cooperate and can increase the pressure in the right side of the heart. And also, like I said, it gives us some information how the shunt between the right atrium and the left atrium. If there's like few bubbles, like less than 5 bubbles crossing the septum, that means it's like a trace. I mean, the shunt is like a trace of shunt. However, if it's like 6 to 20 bubbles crossing from the right atrium to the left atrium, like we call it like a moderate shunt. More than 20 bubbles, if we see a lot of bubbles, like more than 20, it's severe usually. It's limited. It cannot give us details, the surface echo, about the length, length of the tunnel. The TEE, which is more invasive, can give us more detailed information about the PFO, the structure, the surrounding structures, and can give us the length of the tunnel, the thickness, and all this information. So both of them are very important studies. Also, we can see some high-risk PFO features with TEE, or transesophageal echocardiogram, like septal aneurysm is associated with bigger shunt and can give us more stroke. And you can see like the shunt, how large the shunt, more than 30 bubbles with respiration. Also, sometimes we see like a prominent eustachian valve with long tunnels. Also, this is a comparison between the transcranial Doppler and the intracardiac echocardiogram. Like I said, the transcranial Doppler is a very sensitive. It's like it has 95% sensitivity and around 75% specificity to detect PFO, and also it can, based on the shunt, it can evaluate the shunt if it's mild, moderate, or severe. So how we define, or how we say this is a cryptogenic stroke, because like we said, there are multiple different strokes classification. There's classification or types of strokes. So which one we're going to call it a cryptogenic stroke? So the definition of cryptogenic stroke is as it's a brain infarction that is not attributable to a definite cardioembolism or large artery atherosclerosis or small artery disease, despite extensive vascular, cardiac, and serologic evaluation. So what kind of test we start with when we have a stroke? Like I said, we start with a CT and MRI of the brain. We do a 12-lead EKG, and also we do some extra vascular imaging, like a carotid duplex. And also we do cardiac monitoring for more than 24 hours to rule out any arrhythmia or atrial fibrillation. Usually we give event monitor for 4 weeks. And also these days we can also place a loop recorder for longer monitoring and to rule out to rule out AFib, because sometimes it takes more than 4 weeks to catch AFib and to catch atrial fibrillation. And also there was a term in the past used, it was embolic stroke of undetermined source, is the same as thoroughly evaluated cryptogenic stroke. So the relationship between cryptogenic stroke and PFO, like we said, the PFO can allow clots to go from the right side of the heart, through this channel to the left side of the heart, and then can go to the systemic circulation and then go to the brain. The mechanism is paradoxical embolism, that embolus jump from the right to the left, from the venous system to the arterial system. And like we said, the venous clots clot the PFO and then occlude one of the systemic artery. So the history, here we have some history about PFO closure, and like in the introduction, Dr. Zer said, like it used to be closed surgically a long time ago, and they started to close it like since the mid of the last century. I mean, in 1947, Cohen started to close ASD in dogs using atrial wall invagination technique. After a few years, also they used another technique with the right atrial appendage inversion. After that, after the development of the cardiopulmonary bypass technology, it opened the door to close it surgically with success. And then they started after a few years to close them in young female. And then they started in 1972, they started to develop an umbrella-like device for non-surgical treatment. So in the 70s, they started to think about like closing them endovascularly. Then so the closure with the closure device it's new to it has been there since the 2000s, but it was not FDA approved till recently. I mean, the FDA approval of the Emplaza PFO closure occluder device happened in 2017. And then after a year, the FDA approval of the Cardioform septal occluder from Gore Company. So first, the Emplaza from Abbott, it was approved. Then a year later, when the reduced trial was published, the Cardioform septal occluders was published. So you can see, I'm sorry, how the studies and the trials started in the 2000s, and then it took like around 16 to 18 years to approve them. So this timeline show you what happened during the last 20 years to get this device approved. And we're going to go over the main studies that led to the approval of the two main occluder device. So here, I mean, there were three main studies that were published in the New England Journal of Medicine that led to the approval and that showed really a benefit of closing these devices in some patients compared to just medical therapy. So first, the RESPECT trial, and we're going to go in details of we're going to go in details for each study. So RESPECT trial, which was a study that compared to antiplatelet therapy or anticoagulation. At that time, it was the warfarin. And also the primary outcome was recurrent non-fatal ischemic stroke or fatal ischemic stroke or early death after randomization. And the study was significant. After that, there was a reduced trial, which also they used the Cardioform Gore septal occluder device, and they compared with the antiplatelet therapy, and also the number of patients, there was around 64 patients, and also it was statistically significant. And then there's close trial. And they used both devices, but mainly they used the Emplaza device during the study. So how they selected the patient selection criteria, like I said, they focused on the patient of less than 60 years old, because this patient's population, the risk of paradoxical embolism is higher. And there is a score to assess, it's called the ROP score, which we're going to talk about, to assess what the risk of paradoxical embolism. So if you are in patient less than 60 years old, the risk of paradoxical embolism will be higher. That's why they focused on this category as a group that will benefit from closing the PFO and when they have a cryptogenic stroke. So all studies, the patients were less than 60 years old, And also the stroke definition was also in all trials acute focal neurological deficit, and it's either symptoms more than 24 hours or symptoms less than 24 hours with infarct on imaging. So all of them, they have also, they confirmed it with imaging. So also here the selection, how they include the patient in the studies, and also how they evaluated and how they detected the bubbles, how they detected the PFO. So in RESPECT trials, it was visual. They use a TEE, and how it show, and also in REDUCE and CLOSE trial, they used TEE, but in CLOSE trial they used both the TTE and TEE. So in the RESPECT trial, which was it was a randomized, event-driven, open label trial with blinded endpoint, and they randomized the patient to 1-to-1 to Platzer, PFO occluder, or medical management. The medical management was aspirin, warfarin, clopidogrel, or aspirin with dipyridamole. And then they enrolled patients from 2003 to 2011, and then they followed them till 2016. And the study was sponsored by St. Jude Medical, which is now Abbott. And the primary endpoint was recurrent non-fatal ischemic stroke, fatal ischemic stroke, or early post-randomization death within 45 days. So here, it gives you a history of timeline of the respective trial. So when they started to enroll patients, and they keep following them till 2016. So the mean follow-up initial analysis period, the follow-up was for around the mean follow-up was 2.6 years, but after that they did an extended follow-up period till 2016 with a median follow-up for 5.9 years, and then. So the longer follow-up showed statistically significant benefit to PFO closure. So it showed significant 62% relative risk reduction in favor of PFO closure for reducing recurrent cryptogenic stroke, and it was statistically significant. The intention to treat analysis showed 83% relative risk reduction in favor of PFO closure for reducing recurrent cryptogenic ischemic stroke, but it was not that significant initially. It was very close to be statistically significant. But then the longer follow-up was in favor of closing it. So this is the inclusion and exclusion criteria. So the inclusion criteria for RESPECT trial is to have a cryptogenic stroke within the last 9 months, and TEE confirmed PFO, and like we said, the age between 18 to 60 years old. And the exclusion criteria was if we found any other identified cause for the stroke, like large vessel atherosclerosis or AFib, or lacunar strokes, or any other etiology for the stroke. And uncontrolled diabetes, hypertension, or end organ failure was also an inability to discontinue anticoagulation, were all criteria to not be included in the study. The characteristic of patients, like we said, the mean, the average age of the patient were around 45 for both PFO closure group and the medical therapy group. Also, the diabetes, you can see it was low, hypertension. The smoking was it was associated between both groups, 41%. The rest were very low. Also, some of them, they had like some DVTs, and right to left shunt, and half of them like 49%. Atrial septal aneurysm, like third of the patients, they had like atrial septal aneurysm. But also they had like migraine. You can see how migraine was also 40%, around 40% of the patient in both groups, they reported migraine in their medical history. So also, this is to show you how the percentage of patients, what they received, what kind of antiplatelet and anticoagulation therapy. So there was like we said, there were four options: aspirin, Plavix, or aspirin plus dipyridamole or warfarin. And then first they did for the device group, for patient who received in RESPECT trial, for the patient who received the closure device, after the implantation of the device, they received aspirin and Plavix for 1 month, then aspirin alone for 2 to 6 months. So it depends on the investigator. So the RESPECT trial results, it showed if it was very positive. It had a 45% relative risk reduction in favor of PFO closure for any recurrent ischemic stroke or early death. So and it was statistically significant. The greater benefit was in the group that they had like atrial septal aneurysm, which showed 76% relative risk reduction, because they have higher risk of having stroke, this subgroup. And it was very statistically significant. So, like I said, there's some device-related adverse event, and like there was around 13 device-related adverse event, and like there was like 7 deaths, and also there was some there was no device embolization or thrombus during the procedure, or after. There was no thrombus reported. So in summary, for the RESPECT trial, and which was the largest trial for PFO occluder with the longest follow-up, they had 5.9 years of average median follow-up, and which showed significant benefit for PFO closure versus medical therapy, and it showed 45% relative risk reduction of recurrent stroke, and the complication from implanting the device was very minimal, and it had 0 device embolization, erosions or dissections or device thrombus. So it was a benign procedure, we can say, with very, very minimal complication or side effect. Then we have another trial. This trial was for the other septal occluder device. It's called Cardioform. It was the design of this study. It was also randomized, open label, also 64 patients randomized 2-to-1. And they were randomized to PFO closure with the Helix device or Cardioform. The Helix device is not available anymore, and the other group was assigned to medical management. It was just antiplatelet therapy, and the study was sponsored by Gore Medical, and the primary endpoint was also recurrent clinical ischemic stroke through at least 24 months. The endpoints, like we said, recurrent stroke, at least 24 months, or incidence of new brain infarct, as defined as clinical ischemic stroke or silent brain infarct through 24 months. The secondary endpoints, the safety, adverse event, any bleeding, AFib, DVT, PE, or thrombosis, and the performance assessment, technical device success, PFO closure success, and that is measured by the degree of right to left shunt or any residual shunting. And same almost similar inclusion criteria with our previous trial. This reduced trial also cryptogenic stroke within the 180 days. That means within 6 months. PFO with right to left shunt, also with approved by TEE, transesophageal, and also for patients between less than 60 years old, between 18 to 59. And exclusion criteria almost similar. Uncontrolled diabetes, hypertension, any autoimmune disease, alcohol, or drug abuse. And almost similar characteristics with also a mean age around 45 years old. And also they have some septal aneurysm. As you can see, like 20% they have septal aneurysm. So, there was a like we said, there was also a primary endpoint. They focus on the term of silent brain infarction, which is an incidence of new brain infarction. And they noticed that the incidence of silent brain infarction, it didn't differ significantly between the PFO group and the medical group. So the incidence of the new infarction was significantly lower in the PFO group. Group that they were assigned to the device, and the medical group, and there was no difference between both the groups in the silent brain infarction. So they noted also increase of incidence of atrial fibrillation or flutter in the group that they received the device. Like if you can see here with the PFO closure group, there was a higher incidence of atrial fibrillation or post PFO closure atrial fibrillation, like around 6.6%. And it was statistically significant, the difference between both groups. There was some device dislocation, and there was some thrombosis and aortic dissection, but it was very minimal, less than 1%. So in summary, the reduced trial, it showed significantly reduction in the risk of recurrent ischemic stroke and brain infarct compared to medical management or antiplatelet therapy alone. And there was 77% relative risk reduction in favor of PFO closure in reducing the risk of recurrent stroke. And overall, despite the report of some complication, the rates of device and procedure-related adverse events were very low. Then we have another trial. It's called closed trial, which also it's a randomized trial and also around 600 patients. And it had three different groups, like first group, PFO closure with antiplatelet therapy versus antiplatelet therapy alone or with anticoagulation. And the second group is PFO closure with antiplatelet therapy versus antiplatelet therapy alone. And the third group is just, they have contraindication to PFO closure. They were randomized anticoagulation versus antiplatelet therapy. And also the investigators, they had the choice to choose between any occlusal device. There were like 11 devices, but the most commonly occluder device used, it was the Amplatzer PFO occluder, like 51% of the case were occluded by the Amplatzer device. And also the primary endpoint was the reoccurrence of fatal or non-fatal stroke. So this is the primary, and second, there was secondary endpoints of like any ischemic stroke, hemorrhage, TIA, systemic embolism, mortality, death, and performance assessment like the previous trial, success implantation and success, and the safety. And the inclusion criteria, very similar to previous trial, cryptogenic stroke within the 6 months, and PFO with an associated atrial septal aneurysm or large interatrial shunt by TE or TTE, and age less than 60 years old, and exclusion if any stroke from any other reason, or previous surgical or endovascular treatment of PFO or atrial septal aneurysm. So very similar demographics or characteristics, age and history. Also the migraine, also around like here 30%. You can see there, because there were a lot of there was a lot of reports, the association between PFO and migraine, and there were some studies to evaluate if closing the PFO will improve the migraine, but so far it's not statistically significant. But some reports, a lot of patients reports improvement sometimes after closing the PFO. Also here, the ROP score, which is the risk of paradoxical embolism, which here you can see it's average above 7, which is very important to for these patients to get benefit of closing the PFO. So the close outcome, it showed significant benefit of closing the PFO versus antiplatelet therapy to prevent recurrent strokes. So 1 stroke was avoided at 5 years for every 20 treated patients. And study was statistically significant. The study success, there was successful closure. It was 99%, and it was very successful. Also, atrial fibrillation or flutter was higher in the PFO closure group compared to other groups, but it was not statistically significant. But in the previous study, the reduced trial, the atrial fibrillation was higher in the device group. There was no significantly adverse event, but it noted this trial that the PFO closure increased risk of AFib. So in summary, for the closed trial, this is a very high relative risk reduction, 97%. So the previous trial was 77%. This trial showed 97% relative risk reduction in risk of recurrent ischemic stroke with PFO closure versus antiplatelet therapy. And again, overall, the rates of device adverse events was very low. But however, there was some critics for the study that it was not adequately powered to compare differences between the groups, anticoagulation and antiplatelet therapy, and the device between the groups. So this is one of the occluder device. It's called the Amplatzer device, which is a 2-disc. There's a small disc and the big disc. So the smaller disc will be on the side of the left atrium, and the bigger disc will be on the side of the right atrium. We go percutaneously, usually from the groin, and we cross the septum and then we deploy the device under the guidance of the intracardiac echocardiogram. And it's 19-hole wire mesh with polyester fabric, and we can recapture the device, and we can reposition the device if we're not satisfied, or if we see a significant shunt or right to left shunt, and we need to improve or we need to adjust the position. So it's very important to recapture it sometimes and reposition it. So, and this is some examples that we use to guide in how to select the size of the device. We have different device size, and the most common is the 25 millimeter for the Amplatzer PFO occluder. We use it most of the time, but in the presence of atrial septal aneurysm with more than 10 millimeter excursion with long tunnel, like more than 10 millimeter, we upgrade the size to 35 millimeter, and we select this size for better closure of the PFO. And also in patient with lipomatous hypertrophy of the septum secundum, we tend to use the 35 millimeter. So if the anatomy is small and the septal premium length is less than 20 millimeter, we use 18 millimeter device. So how we evaluate patient with PFO? It needs a multidisciplinary team, and it needs coordination between the neurology team, then the cardiologist and the stroke care coordinator and the rehab center. I mean, the coordination with the neurology team is very important. They are the first providers to provide treatment and care for the stroke patients. And they are usually the one who order the initial test and recommend to order the 2D echo with bubble study, or they look for the reason and which category the stroke is. Is it like a embolic? Is it atherosclerotic? Is it related to? Is it cryptogenic? So the neurologist will determine if this is a cryptogenic stroke or not, and then can coordinate with the cardiologist if this PFO needs to be closed or not. So there's the heart-brain team is a concept, is a complementary collaboration of both the neurologist and cardiologist. So both of them together will provide and take care of the patient with cryptogenic stroke and determine if this patient will benefit from closing the PFO or not. So it's very important to coordinate between neurology and cardiology. So here we talk about there's a score. It's called ROP. Or risk of paradoxical embolus. So what it will evaluate the risk of paradoxical embolus in each individual. So like you can see, it depends mainly on the age of the patient. If the patient is less than 60 years old, he will at least get 2 score. So the maximum score is 10. And usually patient will benefit when the score is 7 or higher, that will have a high chance of having a paradoxical embolus. So in patients with above 60 years old, I mean, they will get only 1 point. Above 70 years old, they will not get any point. Then patient without hypertension will get 1 point. No history of diabetes will get 1 point. No previous history of stroke or TIA will get 1 point. Non-smoker will get 1 point. And infarction on imaging will get 1 point. So the maximum, the younger, the higher the score. So if patient is young in the 20s, he will get like 5 points. And if patient is healthy, he will get higher than 7 points. And his the benefit of closing the PFO in cryptogenic stroke will be high. So like I said, that maximum will be 10 and the lowest score is 0. So how we close them? So usually this is a same-day procedure. Patient comes to after we determine that the patient needs to be closed with a collaboration with a neurology doctor, and we bring the patient to the cardiac cath lab, and then it's usually we usually perform it under like moderate sedation or conscious sedation. And in our lab, we almost all of the time we use intracardiac echocardiogram during the procedure to guide us through the procedure and to give us picture of the PFO and the interatrial septum. And also it's very comfortable for the patient instead of using transesophageal echocardiogram. And also we use 2 sheaths, one for the device and one for the intracardiac echocardiogram. It's a very quick procedure. It takes less than an hour. Usually in our labs, it takes 30 to 40 minutes. And like I say, it's a same-day procedure. Like most of the time, patient will go home same day after we perform an echocardiogram and an EKG. And if patient is stable, patient will go home same day. And we place the patient on a dual antiplatelet therapy for at least 1 month, and then we ask them to follow up with their cardiologist or for assessment. Any questions? I hope I covered the topic, and we went over the trials that talk about the benefit of PFO closure with both occluder device available in the market, and how they were recently approved 2017 and 2018. So it's
that's perfect review. Just for the sake of time, we got a few questions. Number one, who should be referred for PFO closure?
For PFO closure, any patient with cryptogenic stroke and less than 60 years old and will get can be referred for PFO closure. And even patients above, I mean, if we think the PFO, if we blame the PFO or we labeled the PFO as the cause of after extensive workup, and if the neurologist thinks that we need to close it, and despite any extensive workup, we could not find any other reason, I think a patient can can be offered PFO closure to prevent future stroke. I mean, the studies were cleared. All the 3 major trials showed high relative risk reduction in preventing recurrent strokes.
And the other question is, what is the antiplatelet or anticoagulation regimen after you implant the PFO closure? Aspirin, Plavix, or
by the trials, they used 1 month of aspirin and Plavix, and then it was at the decision of the operator if he wants to continue aspirin for at least to continue for 6 months.
Is this a same-day procedure, or patient has to stay in the hospital?
It's a same-day procedure. Most of the time, like 99% of the time, patient can go home same day.
Question coming: what is the difference between PFO and ASD in clinical management?
In clinical management, if it's we can both close them the same way, exactly. But the difference, atrial septal defect, there is a tissue loss. In patent foramen ovale or PFO, there is no tissue loss in the interatrial septum. The septum is intact. I mean, there's no tissue loss. In the atrial septal defect, there is a tissue loss, and sometimes it's bigger. The hole or the connection is bigger, and we may need to use bigger device. Like the size of the device to implant will be bigger size, but the management can be the same.
Yeah. Doctor, is there any comments on, from surgical perspective, your approach for ASD or PFO?
Well, I really appreciate the lecture. It was very informative. I think there's a few points to point out. All of these studies were published in the New England Journal. We all know that the New England Journal is very well refereed. And so I think you can hang your hat on the relative risk reduction. I think it's also important to point out that the risk reduction is relative. And so in all reality, the reduction was not so much. It was a reduction of like 10 to 15 strokes out of 600 plus patients. But we also all know that a stroke can be permanent and cause incredible long-term disability. So no one wants a stroke. And so I think the reduction is really important for those people who are at risk, particularly the younger patients who don't have any other reason for a stroke. And we, Dr. Hakim pointed that out multiple times. I think that's important. I also want to give a shout out to John Gibbon, who is, in the surgical literature, is the founder of the heart-lung machine. And a lot of people don't know, but he had worked on this for years and years and years before he was ready to do a patient. And he indeed did do an ASD repair as his first patient. And that patient lived, but his next 4 died. And he only ever did 5 open heart procedures. He became disheartened after the 5th, and so he didn't do any more. But it was really an ASD that launched modern cardiac surgery and the ability to put a person on the heart-lung machine while we work on repairing structural defects within the heart. So I think it's important to remember John Gibbon as, the founder of the heart-lung machine, which is an important point. The other comment I just wanted to make briefly was surgeons are well aware of paradoxical emboli, because we open up the heart every now and then and see a piece of thrombus caught in the patent foramen ovale. And all of us have a picture somewhere within our repertoire showing half of a thrombus sticking out of the right atrium with the other half headed through into the left atrium, which will cause a stroke. And we all say, wow, and take a photograph of it at the time of surgery. So this paradoxical embolism does exist. I've seen it in action, and this is a means by which to prevent that.
Correct. That's the purpose of closing the PFO or ASD, to prevent the paradoxical embolus from jumping to the systemic circulation and causing a permanent deficit of in the patient.
Exactly.
Yeah. Is there any difference in terms of, Dr. Hakim? So do you usually routinely do TEE for every PFO, or you are satisfied with the echo?
Sometimes I'm not satisfied with the echo if the patient's history suggesting, for example, patient has multiple strokes in the past and we could not find any reason despite the workup. I order a TEE, and sometimes we catch some PFO with TEE. And like I say, the gold standard. If the surface echo or the 2D echocardiogram suggests interatrial aneurysm and the bubble study was not positive, I will order a TEE to better characterize interatrial septum and detect any PFO.
Zahir, one of the original inclusion criteria, at least they wanted it to be when they were contemplating putting together inclusion criteria for this trial, particularly the St. Jude one, was migraine. It's never made sense to me why a PFO causes a migraine. Any ideas on that?
There are different theories. I mean, sometimes they said like the velocity of the vessel caused some change in the circulation. Also, sometimes like small embolus can jump and cause some spasm. There are many theories, but there's no definite answer yet. Even closing it did not prove it was not statistically significant. But some patient reported, oh, we felt better.
So yeah, it's a discussion. Patients.
certain patients may benefit. It can decrease, especially the patient with migraine with aura. It can improve. That was a sub-analysis, and it showed the attacks, the number of attacks or of migraines are significantly reduced in the migraines with aura, but it's not yet indicated. But it's a talk between the physician and the patient to tell, look, you can get better, and it may not get better. So it's your choice.
Some evidence there. Okay, thank you so much. Doctor, is there any final comments or any questions?
No, I really appreciate the informative lecture. I learned a lot.
Thank you.
Thank you so much, Dr. Hakim, for your time, Dr. Zair, for your time as well. And for you, all the audience staying with us, thank you for being with us and for the questions. Again, this is Shadi Reis from Detroit Medical Center. This is DMC Heart and Vascular Heart to Heart webinar series. We'll come to you again on the third Thursday next month at 7 p.m. With a new topic to be announced soon. Thank you so much for joining us, and stay safe. Have a good night.
Thank you. Thank you. Good night.
I hope you have enjoyed this DMC Medical Group video. To find more content, webinars, and physician videos, visit dmcmedicalgroup.com.